everyone, my name is Micah. I am a PGY2 resident currently as I record this video. We are going to talk about trauma. This is actually a topic given to me by my residency to present at Didactic. They asked me to do adults, pediatrics, pregnancy, geriatrics, and I felt like that was all the populations. This is a lot to cover. So I think we're going to split this into two videos. Let's do adults and then the special populations in a second video. The thing about starting with adults is this is kind of your baseline, right? This is where you're going to develop your algorithm, and honestly, it's the majority of what you're going to see. And then we'll talk about how to adjust for those special populations down the road. So if you've not taken ATLS at this point, that's okay. We're going to use ATLS as the 2018 version, which right now is the most recent version. We're going to use that as one of our primary resources, as well as Rosen's and Tintinalli's. So the thing with starting with adults, like I said, we're going to build this algorithm, and this should be every patient every time you walk into the resuscitation bay. I follow this algorithm even for non-trauma patients, just because it makes sense, and if I always have the same approach and I don't deviate, then I've got a pattern to follow, right? And I joke that in emergency medicine, we tend to do the majority of our thinking before time, because when we have that patient in front of us, we don't want to be thinking about what am I supposed to do next. We need to be thinking about, what's the adjustment I need to make. So you want to get this to a point where it's just sort of trigger reaction, right? So the first thing you do when you walk into that resuscitation bay is going to be the primary survey. And it's the ABCDE. We always add G in my shop. A is airway maintenance, and in a trauma code, you probably need to restrict the C-spine. So if they don't come in a collar, you might need to get them in a collar. That's step 1. Step 2, breathing and ventilation. 3, circulation with hemorrhage control. D, disability, which is assessment of the neurologic status. And then E, exposure, environmental control. And then don't forget glucose. So the only thing that really varies on this is if you've got an obvious C issue where someone's actively bleeding onto your floor, put a finger in it and stop it. That's the only big deviation. And always get your glucose. So you don't move on to the next step from you don't go on to B unless you have A under control. You don't go on to C unless you have B under control, et cetera, down the line. So you really do want to try and follow this step by step. So let's start with and then adjuncts. So you're going to do the survey, but here are things that you can get while you're doing that survey. It's the EKG monitoring, get them on a pulse ox, check their ventilatory rate, capnography, ABG, get that pulled, whatever you're getting. So ATLS actually has urinary and gastric catheters in here, as well as X-ray imaging. Yeah, and FAST too. Like, those are all part of the primary, according to them. The thing is, those don't really happen fast enough most of the time, where you could probably start your secondary survey as these things are happening. So just keep in mind that there is a little bit of flexibility there. So I'm also going back a little bit. The capnography to me right now is one of my passion pieces, where I'm really pushing to have all of my patients on end-tidal CO2, and this especially with codes like CPR in progress. I really, really want that end-tidal CO2, because that is a much better barometer of what's going on than their oxygen saturation. That can take several minutes for a patient to decompensate, where at end-tidal CO2 you're going to get some changes within seconds. And I don't know why ABG is on here. Yeah, you can draw it, but like, you're not, unless you get a point of care, which I've never been in a shop that does. You're not going to get that information for quite some time. So what the big advice that I go back to, which was from my ATLS instructor, is he says, if you see something, fix something, then go back and check it the same way you did before. So as you're going through, you check your breath sounds bilaterally with your stethoscope, and you've got diminished breath sounds on the left, and so you do a needle decompression. Don't wait for the X-ray to see if they had a tension pneumo that you resolved. Listen again with your stethoscope, so you have a one-to-one comparison of before my intervention and after my intervention. So, okay, let's go a little bit deeper. Primary survey, starting with the airway. First, you assess, is a clear and protected airway. So assess and then clear and protect the airway if you need to. So that can be the jaw thrust or the chin lift, because you're maintaining spine precautions. You might need to suction them out. If they're not protecting it, you need to get an ETT intubation with inline stabilization. So, you're probably not doing direct on these. I think it's absolutely reasonable that you jump to some sort of video laryngoscopy. So, either a McGrath, which I just had my first exposure to this year, and I think they're awesome. The Glide Scope is really cool, but the McGrath, man, you can slip that in, you can have it all prepped, and have video laryngoscopy without having to turn your head, without having to kind of mess around. And the time to intubation with a McGrath is equivalent to a direct laryngoscopy, as opposed to a Glide Scope, which can prolong the intubation process. I think that is nice about a Glide Scope or a similar situation is when you take a look, RT can also take a look. You're attending, that it's a lot easier for other people to visualize as well, and they can assist you with intubations as you're learning. And then again, a surgical airway if there's significant bleeding, obstruction, or if you just can't get that laryngoscopy. So those are all options. They always say the hardest thing with the surgical airway, so a crike, is not doing it; it's deciding to do it. So the whatever it is, 7 P's of the airway is preparation, pre-oxygenate, position them, pre-treatment, paralytics and induction, placement with proof, and post-intubation management. Before you take someone's airway, you should probably have all these lined up to the best of your ability. We'll go into these a little bit more here. Preparation, so me. I'm not a big mnemonics guy because sometimes I have a hard time remembering what the mnemonics are or what they were for. But as you're building your algorithm, they can be helpful. So make sure you have suction. You depending on the situation, you might want 2 suction containers set up. Make sure you have oxygen. I try to have 2 oxygen set up so I can have my bag valve mask going and I can have a nasal cannula or non-rebreather, whatever the case might be. Have multiple airways. So, if you're able to do direct, that you have a direct for backup, or, maybe your video is your backup, or someone's grabbing the video while you might try direct. Bougie is a big one, right? And if it's a really bad case, having someone grabbing that crike kit early. Pharmacology, you know what you're going to use for your RSI drugs. Make sure, if you have a pharmacist on hand that they're pulling them, or your nurse or whoever it is, make sure they're on the monitor and make sure you have an escape plan. So if this goes wrong, what is the next step? Next, pre-oxygenate. This is a hard one to do because sometimes you just don't really have the time, right? So again, arguing for 2 oxygen setups, both of these have nasal cannulas in them. If they're spontaneously breathing, you can put non-rebreather on them, and your goal should be trying to hit a couple of minutes, 3 minutes, 4 minutes, even if you can, to denitrogenate their lung space and make it enough room for oxygen as possible to give yourself that prolonged intubation time. And then if they're hypoventilatory or apneic, you can bag valve them as well as do the nasal cannula. This is one of the ones that I find a harder time adhering to just because of the timeline and the decompensating patient in front of me. Position them. Another one I'm working on is always making sure that they are at my belt line. And when I don't know if being at the belt line is the best place necessarily, but if you always want it at the same place, right? So that muscle memory can stay consistent. You're gonna have to remove the C collar, and you're gonna have to have someone hold precautions. But because you want to still protect it, but you need them in a position where you can visualize everything that you need for intubating, and then again, belt line, at least be consistent so that you start building that muscle memory. Pre-treatment. See, this is something that you could have been working on already. Where I'm talking, real world, doing multiple things at once. Resuscitate by correcting volume. Whatever else you can do that can be done early. Depending on the case, it might be prepping that epi push for the peri-intubation. Getting good hemorrhage control if that's something that's going on. Whatever. All right, paralytics and induction. These are the 3 big ones for your induction. Etomidate seems, in my experience, is the one that's the most go-to. zero point 0.1 to zero point 0.3 mg per gig. It's got a rapid onset. It does carry a risk of adrenal insufficiency, ARDS, and it lowers the seizure threshold. So consider that, right? Seems like most people pull for etomidate. I do see people use ketamine sometimes. It does increase the sympathetic drive, increases blood pressure, heart rate, and also bronchodilates. So, if this is an asthma case or something like that, that can be pretty helpful. And maybe increase ICP, but like the literature truly seems to be out on that. That it's maybe not as bad as it was once thought. So, and then propofol, which I've been in shops where propofol was the absolute go-to for basically everything. Rapid onset, yeah, it can cause hypotension, but if you've got enough room on the blood pressure, it can go very very quickly, and you can stop seizure activity. For paralytics, it's basically the Sucks versus Rock. I know some people do Vec. I guess I've not been in a shop where Vec was very popular. Sucks is 1.5 mg per kg, rapid onset, rapid off, 8 to 10 minutes. The contraindications like crush injury, burns, basically all these really relate back to the idea that it causes hyperkalemia. And that's true, and especially on a patient where you maybe have no history, that can be a little bit more concerning. But succinylcholine also raises potassium by about 0.5 is all. So unless you're in kind of a danger area already, odds are it's not going to push you over the edge. Rock, on the other hand, rapid onset, long lasting, right? So 45 minutes. And that's leads to your dreaded unable to intubate and ventilate scenario. So, like, you paralyze this person and you can't get the tube and they're paralyzed, and now maybe you're having a hard time bagging. What are you going to do, right? You got 45 minutes to try and figure this out before this drug wears off. So, that's the biggest argument against rock. Placement with proof. If you're working with anesthesia, I feel like a lot of my anesthesiologists that I've worked with say the only real way to prove it is by seeing it go through the vocal cords. That's probably great in an operating room where you're often working in perfect environments, or near to. In a trauma code or a medical code, that's usually not the case. I mean, sometimes you're intubating in a pool full of blood and you're just aiming for where the bubbles go. End-tidal CO2 or colorimeter. End-tidal CO2 is better because it's going to give you fewer false positives. Colorimeter can change with, with stomach acid. So symmetrical chest rise, equal bilateral breath sounds. This is an important one to me. I was taught to listen to the stomach first. So when you intubate someone, what's the worst place you can put it? In the esophagus. So if it's in the esophagus, you're going to hear breath sounds in the stomach, right? So why not listen there first? Make sure you don't have any breath or any bubbling noises, and then go to the left, because the next worst place to put it would be in the right main stem. And so now you can confirm that you have left breath sounds. And then if you got left breath sounds, you probably got right? But you still got to listen all the way through. And then order that chest x-ray demonstrating placement. That's really more for, did you put it deep enough, not or too shallow, whatever. And then post intubation management. Analgesia, sedation, making sure to get an OG tube in just to help prevent aspiration pneumonia. I guess in my shop, again, Fenton Versed is probably the most likely go-to. I've also been in shops where Prop was a what they'd like to get them started on, and then it was often changed upstairs once they knew a little bit more. There's problems with keeping people on Prop for too long. So this is taken from MCRIT. This is not mine, but this is the failed airway algorithm. And I think we have a tendency to not follow this very well, which we should. You do your RSI, you get your first attempt, you make it, cool, confirm, you're done. If you miss, you get a second attempt, and everyone always says, make sure you're making some kind of adjustment, because doing the same thing in the same way twice just leads to failure. So maybe that's here they don't have it in this order, but maybe that's adding the bougie or doing it with the video laryngoscopy, whatever. You fail again, your attending is going to do it. If your attending can't get it, now you need to talk about moving on from the idea of an ETT tube. So SGA placement, so a supraglottic device like LMA can happen. Uh, One of the cool tricks I was taught by an anesthesiologist is if you drop in an LMA, that hole in the LMA is going to be right over the vocal cords anyway. A lot of times you can take a small ETT tube and just thread it through there and intubate through the LMA. And if that fails, then it's time to crank. So also, I've definitely been in situations where we've had to call anesthesia in, and I would call anesthesia early if it looks tough. I've definitely started my intubation process and called anesthesia at the same time. And if they come down and I don't need them, that's fine. At least for me, it's fine. They're not always happy. Okay, so then moving on from airway, you've secured the airway, you've got your intubation, everything's good. You got bilateral breath sounds. Now you're gonna move on to breathing. You got to ventilate with 100% oxygen and monitor O2 saturations. You auscultate for breath sounds. So make sure you got bilateral breath sounds. You listen for any, you know, absent breath sounds, crackles, rills, wheezing. You're going to look for deviated trachea. Are there any open chest wounds? Is any abnormal chest wall motion, like for a flail fracture? Any crepitus at the neck or chest, thinking like a ruptured esophagus. And then if you think that there's a tension pneumo, I consider immediate needle thoracostomy straight out of ATLS. Just pop that needle in, right? And if you think it's a hemopneumo, consider putting a chest tube in. And I'd like to actually, I should go back. I'd like to point out that does not necessarily include X-ray imaging at this point, right? This is still clinical bedside. You might not have time to get that chest X-ray in a decompensating patient to see if there's actually a tension pneumo going on. Okay, then moving on to circulation. So, you're assessing for volume status. You look at their skin color, the cap refill, checking pulses, what's their blood pressure. Get that access to large bore peripheral IV catheters. So typically we grab 18s if it's something that you might be considering massive transfusion protocol. If you grab a 16, or even a 14, you can actually transfuse through that faster than you can through a Cordis. Throw in 2 liters of warm crystalloid solution, and if indicated, you can go to blood after that, 1 to 1 to 1. I know there is some literature movement now that instead of doing 2 liters, it should only be 1 liter. So, check with your shot protocol on that. Direct pressure to breast external bleeding. Stick a finger in it. If you need to, consider central venous or IO, interosseous. There's a push right now to get humoral IO as opposed to tibial. So if you get it down in the leg, you're looking at up to 4 or 5 minutes, I think, before that medication is going to hit the heart. That's what I've been taught. I've actually seen drugs like RSI drugs go into the IO that it's not near that long. But if you get the humoral, you're within seconds that it's going to reach the heart. So you're going to get a lot quicker distribution of your drug by going through a humoral intraosseous access. And then, are they having tamponade? Do you need to consider a pericardiocentesis? These are things that we can fix quickly at the bedside to save our patients. And then, I guess this does kind of come in later, but consider left lateral decubitus position late trimester pregnancy. So you push the belly out of the way so that they're not compressing that inferior vena cava. And then also a newer thing that we've been talking a lot about lately is, do you need to give TXA? If they're bleeding out internally, this is our pharmacological way to stick a finger in it. So talking about bleeding out, let's talk about classifications of shock. Blood loss class 1 being the least amount, up to class 4 being a lot. In class 1, you're talking like 750 milliliters, up to 15%. I'm not going to review each of these individually because that would get pretty boring. But the things to note here are that the more blood you lose, the faster your heart beats, right? Because you've got less volume to shove around, you're going to have to beat faster to shove what you do have. That's going to come up more in our geriatric conversation, but that is something that we need to consider, right? But that could be altered by medications they're on, or I mean, mainly medications they're on. Same with blood pressure. Normal, normal, decrease, decrease. So you have to lose at least 30% of your blood based off of this, right? 30% of your blood to have a decrease in blood pressure. So if you have a hypotensive patient that's a trauma code, barring anything else, if it's just simply because of hemorrhagic shock, man, they've already lost 30% of their blood. We're talking almost 2 liters out the door. Uh, they're in some trouble, right? So I've been trying to push myself to look more at pulse pressure, just because that's the one that it can get messed up by medications, but it has one of the earlier obvious changes. Your pulse rate can be tachycardic because you're in pain. You can be tachycardic because you're nervous. Even in minor trauma codes where it was kind of I don't want to say an overcall, but where there ended up being no significant damage, that the patient was often tachycardic because they had 8 people standing around them and they're ripping off clothes and they're getting thrown into a C collar and all this kind of thing, right? But pulse pressure, as soon as that start to decrease, that's a concern, right? Then we're already talking class 2 shock. So then moving on to disability. So maybe we should recap. You walk in, you check your airway. Is it patent? Do you need to suction it? Do you need to take it? Check your breathing, bilateral breath sounds, any weird deviation of the trachea or asymmetry that you need to be concerned about. Listen to their heart. Check their pulses. Cardiac's in control. Make sure there's no brisk bleeding that you need to take care of. And now we're moving on to disability. Perform screening neurologic and mental status exam. This is really easy to overcomplicate. You're not doing a full neural exam. You're just going to look at pupil size and reactivity, limb strength and movement. Do they seem to be moving all 4 extremities equally? You can do a grip strength. Check them if they're A and O times what. Do they know what's going on? Do a Glasgow Coma scale, and that's pretty much it. And here's where you would consider glucose, because one of the easiest things to fix if someone is altered is a hypoglycemic patient. So don't miss the glucose. And even consider too, they might be a trauma code, but I just had a patient the other night who came in as a trauma code, but really they were a trauma because they first had an MI. They first had a heart attack while they were driving, and that's what led to the trauma. So consider glucose. Get it every patient every time. To review the Glasgow Coma scale, I don't know why. I have a hard time remembering this, but it is what it is. Best motor response, do they obey, localized pain, withdrawal, flexion, extension, or none? Verbal response, they're oriented, confused, inappropriate words, or incomprehensible sounds, or none. Eye opening, spontaneous to verbal to pain, none. Anything less than 8, theoretically, you would intubate. Don't follow that as an exact rule because there's a lot of reasons to be less than 8, and that doesn't necessarily mean that you're going to lose your airway. But it's an easy thing to argue, right? And then the other thing is Glasgow Coma scale is only validated in trauma patients. So don't be dropping a GCS for your COPD or whatever. Also, one of the things that's often pimped is the lowest score on a GCS scale is 3. GCS scale. That's like saying ATM machine. GCS only goes down to 3. So don't give anyone a 0. And also, reassess this. Do that multiple times. I had someone come in with a GCS of 3, and once we started getting IV access and stuff like that, all of a sudden they were a GCS of like 9. They just needed a little extra stimulation, and me sternal rubbing wasn't doing it for some reason. And then last, primary survey exposure. Completely disrobe the patient and inspect for burns, toxic exposures. If you're concerned about this, make sure to have your PPE in or on. Every patient needs to be disrobed. I know it sucks for them. However, that's just the reality of the situation. Log roll them. Make sure you check in the back. Palpate the thoracic spine, flank, back, and buttocks. And then prevent hypothermia when you're done. Throw a good blanket on them. Okay, so that moves us on to the secondary survey. That's a lot already, right? Like the primary survey alone is a several hours long lecture. So this is a little bit more review. But secondary survey, history, get your allergies. What medication are they currently using? Because you need to know how that complicates your picture. Past illnesses, what chronic conditions are they have? And often they don't know, but they can tell you the medications. You might have to piece that together. Are they pregnant? Okay, last meal. I kind of I try and remember to ask it, but like honestly, if I have to sedate them and intubate them, it's going to be RSI anyway, and like there's only so much we can do. And then events, environment related to the injury, like get some details from them of what they remember and what happened. And then you move on to your physical exam. And I just start at the head and work my way down, essentially. You don't want to miss anything. So start with the head, the HENT, check your maxillofacial structures, your C spine and neck. Then you go onto the chest, abdomen, pelvis, et cetera, et cetera. We'll go into these a little bit more here. So with the head, you're looking for lacerations, contusions, evidence of fractures. ATLS says check the visual acuity. I would argue that you don't really have time to actually do a Snellen chart. Just ask them if they're having blurred vision. But by the books, you would be doing a Snellen. Check the pupillary size. Look for hemorrhage of the conjunctiva and of the fundi. Is there penetrating injury? Do they have a knife sticking out of their eye? Do they have contact lenses in? You should probably remove those. Is there any dislocation of the lens? Any ocular entrapment? So you can kind of knock all these out, or a lot of these out, by just asking them a couple of questions, flash a pen light in their eye, and then have them follow your finger, and you've done the majority of these. Maxillofacial structures, you need to palpate all the bony structures, especially if there's any kind of facial trauma that you can see, any kind of abrasions or anything. You want to assess, is there any concern of occlusion? This is kind of taking another look at their airway at the same time. You're doing intraoral examination. Are they missing any teeth, any chipped teeth? Just had a patient the other day who lost half a tooth, and we're not really sure where it went. And there was concern that it was in the airway. And then also assess the soft tissues, boggy structures, and stuff like that. C-spine and neck. Anyone with per ATLS, patients with maxillofacial or head trauma should be presumed to have a cervical spine injury, and cervical spine motion must be restricted. That's pretty much every patient I have. I'm going to throw in a C collar, and I know there's a lot of contraindications to it. If they're super confused and I can't sedate them, or if they're old, they're at a risk for pressure ulcers. But if you're going to be able to clear it as quick as possible, I would seriously consider a C spine in basically almost everyone, especially because the absence of neurological signs does not exclude injury. So you want to inspect it. You may want to palpate it, right? Or, I mean, you need to palpate it, but you may want to auscultate too and listen for any kind of crepitus. If you've ever felt the Rice Krispie pop sensation underneath someone's neck, whew, you do not want to miss that, right? So on the chest, you're gonna look at it. All these starts with looking at it, right? And we're talking about doing these essentially within seconds. You're going to palpate the entire chest cage. You can just put a hand on each side of the chest and start pressing and say, is this certain? Is this certain? Auscultation, percussion. Again, by the books, percussion. Realistically, in a trauma bay, you're not going to hear anything anyway. You're going to grab a chest x-ray and an EFAST. Both of those are going to take a look inside the chest. Both of those are considered adjuncts, right? And actually, I believe those actually fall in the primary survey adjuncts, but realistically, they're going to happen here. Move on to the abdomen and pelvis. You're going to take a look at it again. Do you see any bleeding, any bruising? You're going to push on it. Anything hurting? You're going to get your FAST. You're going to get your CT abdomen and pelvis if it's indicated. And here the point is specific injury is less important than determining if operative intervention is required. So do they have a spleen lac versus, hollow viscous? I don't know. Who cares? What I care about is, do they need to go to the OR right now? You don't always have to separate out your pathologies. Next, the perineum, rectum, and vagina. This is one that I'm definitely not good at checking every time. Look at the perineum for contusions, hematomas, lacerations. A digital rectal exam. I've had this conversation with the trauma team. They don't seem to think that it's indicated every time. I agree with that, but squeezing the butt cheeks might be good enough for for making sure that they're neurologically intact, but that will not tell you about any presence of blood or if there might be a rectal trauma. So checking the integrity of the rectal wall. And the same with the vaginal vault, right? Like if you're concerned for some kind of saddle injury or something like that, you should look, see if there's presence of blood, lacerations, that kind of thing. Next, the musculoskeletal system. Now you're looking at the extremities. You're going to look for contusions, deformities. You're going to palpate for fractures, laxity, in the joints, any abnormal movements. It's easy to accidentally move this one way up the list, but as far as things that are going to kill your patient right now, it's not a femur fracture. That's not to say that femur fractures can't really be serious, but you're not going to lose them the next 10 seconds because of that, not compared to airway or breathing or whatever. And then you're going to do your neurological system. Again, your GCS score. You're going to be monitoring for changes. And you're also going to be, here's where you check like peripheral nerve changes. So you might do sensation. Again, equal grip strength, movement, just rechecking all those things. Now, secondary survey adjuncts, x-rays of spine and extremities. Forget the x-rays of the spine. They're not super helpful. But pretty much every patient, every time, chest, pelvic x-rays. And then whatever extremity x-rays are indicated. So if they've got concern of a fracture or a knee pathology or whatever, you're going to add those on. CT of the head, every patient, every time, I would say. Especially if it's trauma code, right? And then also CT cervical spine would be part of that. And then if it's indicated, chest and abdomen. And if you're getting a CT of the chest and abdomen, they can reconstruct the thoracic and lumbar spine from those images. So you don't have to order additional spine images for that. You can just get it all off of that one. And what the hell, if you're sending them anyway, if there's not a concern for contrast or radiation, which 9 times out of 10, that's not real high on the list of things we need to worry about right now. You can spin them just all the way up and down, right? So, those are the major X-rays and CAT scans. Contrast urography and angiography. Urography, I guess I've not really had it come up yet where I was that concerned about a bladder or urethral injury at this time. But angiography, right? So angiography of the chest or the abdomen, if you're concerned about a possible transection or dissection. I mean, transection, if they're transecting, like, that's you're not sending them to the CAT scan anyway, right? Do not send unstable patients to the CAT scan. Transesophageal ultrasound. Again, maybe this is a shop thing. Like, that's never going to happen for us. I do fast, e-fast, the majority of my patient. I mean, I fast every patient, every trauma patient, and then e-fast probably almost all of them. If I'm going to fast, why not e-fast, right? Bronchoscopy, esophagoscopy, etc. I mean, those are just extra things that you can get if they're indicated. And that brings us to special populations pediatrics. We are going to take a break here and switch to a new video because we have discussed all the baseline things for adults and kind of the overview, building that scaffolding. And again, that went very quickly, but hopefully you've had ATLS by now. If not, that should give you an indicator of where to go on that. So again, starting with your primary survey, airway, breathing, circulation, disability, exposure, and environmental, and just follow one after the other. And then you go on to your secondary survey, you get your sample history, and you just start at the head and work your way down, looking at every single part of that patient, figuring out what you may or may not need to do. So take a break. We'll come back and we'll do special populations. All the special populations, not just pediatrics.